This is Stacy Shaleski, and I'm doing my evidence-based practice and theory on thyrotoxicosis, also known as thyroid storm. Thyrotoxic crisis, or what is also known as thyroid storm, is a life-threatening condition in which patients with underlying thyroid dysfunction inhibit exaggerated signs and symptoms of hyperthyroidism. In this picture, you will see where the thyroid is located and where, as a nurse, you would be to palpate the thyroid. Statistics show that only 1 to 2% of people with hypothyroidism will develop thyroid storm. However, of those, the mortality rate can be as high as 50 to 90% if left untreated. Another thing to note that atrial fibrillation, which goes along with the thyroid storm, occurs in about 20% of older patients, but it is important to remember that it is rare in patients under 50. The pathophysiology of thyroid storm is not completely understood. However, it is thought that the excessive levels of thyroid hormone are not necessarily from the thyroid gland itself, but from the conversion of the bound thyroid hormone in the blood to an unbound form. The unbound form becomes active and can easily enter the peripheral tissue, producing a dangerous and possibly life-threatening hypermetabolic state and increased sympathetic nervous system activity. I've listed here some of the precipitating factors. They would be pregnancy, surgery, trauma, induction of anesthesia, diabetic ketoacidosis, infection, myocardial infarction, or just plain non-compliance with anti-thyroid medications. The signs and symptoms of thyroid storm are sudden onset of fever, which is an important one to note, also tremors, flushing, profuse palm sweating, tachydysrhythmias, nausea, vomiting, diarrhea, weight loss, fatigue, muscle weakness, and atrophy. The following is a case study in an article entitled "Is it Thyroid Storm or Atrial Fibrillation?" by Elaine E. Steinecke. The case study is: Jeff Seaton, 54, arrives in your ED with irregular tachycardia that began about 90 minutes ago. He says he's had brief episodes of palpitations over the last couple weeks, but no sustained tachycardia until now. He feels weak, sweaty, anxious, and uncomfortable, but says he isn't nauseated. You take his vital signs and come up with the following. His blood pressure is 100/62. His pulse is 152. Respirations are 18. Temperature is 100 degrees Fahrenheit or 37.8 degrees Celsius. In the last few weeks, he's lost 7 pounds and had increased appetite, heat intolerance, and muscle cramping, which he attributes to working in the yard. Mr. Seaton has a history of hyperlipidemia but no other medical problems. He doesn't smoke and drinks only about 1 alcoholic drink per month. He's taking atorvastatin, multivitamins, a calcium supplement, and aspirin. He has a family history of hypertension and coronary heart disease. An ECG shows atrial fibrillation with a rapid ventricular response. His lungs are clear to auscultation. His heart rate is irregular with S1 and S2, but no murmurs were auscultated. His abdomen is soft and non-tender, and his extremities are without edema. The ED physician prescribes IV infusions of diltiazem for atrial fibrillation and lorazepam for anxiety. What's going on with Mr. Seaton? Signs and symptoms of hyperthyroidism can be subtle and nonspecific, and signs and symptoms of thyroid storm can overlap with many other conditions, including alcohol or drug withdrawal, panic disorders, heat exhaustion, and heat stroke, neuroleptic malignant syndrome, and aneurocolitis cholinergic or adrenergic drug toxicity. Thyroid function tests can confirm the diagnosis, but the results may not come quick enough. Therefore, nurses should rely on the use of assessment skills to recognize the hypermetabolic state of thyroid storm so that treatment is not delayed. The cardinal signs of thyroid storm once again are high fever, marked tachycardia, atrial fibrillation, heart failure, neurological symptoms such as agitation and restlessness, and gastrointestinal symptoms such as nausea, vomiting, and diarrhea. Some of the immediate actions for a nurse who is taking care of a patient with thyroid storm should include establishing an IV access to get the patient fluids and replace any fluids that were lost due to nausea and vomiting. A nasogastric tube should also be placed to administer antithyroid medication, simply because these medications are not available in IV form. It's important to oxygenate the patient, which should be a priority, and the nurse can provide additional supportive care measures during thyroid storms, such as reducing the fever by the use of a cooling blanket, ice packs, and fans. However, shivering should be avoided as this can actually increase body temperature. Acetaminophen is an antipyretic of choice because aspirin or silicates can increase the circulatory levels of the thyroid hormone. Treat dehydration and electrolyte imbalance, typically with those containing dextrose. According to the evidence-based practice and theories that I investigated, some of the medications you would most likely give to a patient with thyroid storm would be PTU, which blocks the synthesis of thyroid hormones and inhibits the peripheral conversion of T4 to T3, potassium iodide solution, which you would give 1 to 2 hours later to prevent release of stored thyroid hormone into the system, hydrocortisone, which is helpful as the thyrotoxic state depletes cortisol from the adrenal glands, and also beta blockers, which helps treat the tachycardia, tremors, and restlessness. I want to thank you for participating in this YouTube presentation, and please, in conclusion, remember that untreated thyroid storm is fatal. Prompt recognition and treatment of this disorder is crucial. Rapidly identifying the underlying cause of thyroid storm can help you manage the emergency and may save your patient's life.